Hello, everyone. My name is Peter Pruyn, and I am beyond delighted to be in conversation today for the second time with Heather Guidone about endometriosis and trauma recovery. Welcome back, Heather.
You. It's so great to be here. I appreciate it.
I appreciate it too. And Heather, just for audience members who are seeing you for the first time, can you just give them a thumbnail sketch of yourself?
Absolutely. So I am the program director of the Center for Endometriosis Care. We are a center of expertise in endometriosis based in Atlanta, and also a person with endometriosis myself. So that really kind of informs my work and my efforts. And I really work, on the advocacy side in terms of education, awareness, support, policy work, legislation, things like that. Because I think it's important that our community is represented at all the tables where decisions are being made.
Well said. Well said. Well, I couldn't be happier that you'll come back for this. And just to give folks a little background, this is actually the second conversation Heather and I have had about endometriosis. And if you haven't watched the first one, I really encourage you to watch it before watching this, because in that first conversation, Heather gives a really elegant and accessible explanation of the disease of endometriosis, its treatment, but then also, most importantly, goes into many of the myths that have persisted for so long about the disease. And the story of today's conversation is after we recorded that conversation, Heather and I were chatting, and we kind of realized that there was a whole other conversation to have about endometriosis, specifically around its relationship to trauma and also trauma recovery. And so that's why we're back here today. So what we're hoping is that in this conversation, Heather will provide a medical perspective and a patient perspective of endometriosis, and I will do my best to share my perspective as an EMDR trauma therapist. How does that sound, Heather?
Absolutely. And the one thing I did want to say too, although it's our second Zoom, you and I have been in touch on this disease for so long, and you're doing such good and important and informed work in the space. So I want to thank you. It has been a pleasure to kind of watch your journey as you evolve more and more on the endo side, and we appreciate you. So thank you.
Thank you, Heather. That's very kind. And as I said last time, whatever progress I've made is largely due to you. So thank you. So to just sort of kick things off, I'm wondering if you could just sort of give us a sense, Heather, of what are some common forms of trauma that you find individuals with endometriosis experience?
So much. And if I may, I feel I would be remiss if I did not put it out there. Anybody who's experiencing any kind of distress or finds any part of our conversation triggering, please utilize 988, 988lifeline.org. I don't want anyone to certainly be triggered, but please know that there are resources out there.
Thank you,
But
Heather.
in terms of what we think about with trauma and endometriosis, well, first of all, let me just preface by saying, endometriosis is a chronic and progressive disease. It's defined as a systemic inflammatory disorder where we see endometrial-like tissue found elsewhere in the body. It's been documented in virtually every major organ system. And as I said, it's chronic and progressive. So when you think about that, you start to understand immediately that the impact and the debilitation of the disease really is truly systemic. And I know a lot of times when we talk about things like trauma, immediately folks will think, combat trauma, abuse, sexual violence, disasters, things of that nature. And yes, that's all true. But certainly we can see absolutely possible to see experienced trauma in the healthcare setting. And when we're talking about living with chronic diseases, chronic illnesses, chronic conditions, particularly those which could be compounded more so by racial or ethnic or gender disparities in the healthcare setting, certainly you can imagine the level of trauma that is experienced by someone who's living with what can be an absolutely crippling and debilitating disease. when we talk about trauma, it's really a relative experience, right? Um, it could be acute, it could be chronic, which is the result of prolonged and repeated trauma, if you will. And it may be very complex and intertwined. And those are sorts of things that we can see in endometriosis. All of them may be present because the disease is so multifactorial. And the effects can span the life course, even before, early life when the symptoms first appear before diagnosis, after diagnosis, and really for decades thereafter. Um, Symptoms really widespread and debilitating. They can also vary. They can be very severe and unpredictable. So all of this really builds on to that trauma aspect. Things like impact on education, impact on work and career choices, your earning capability, your family building choices, personal relationships, everything from physical to mental to emotional. People with endometriosis are already struggling with really highly challenging life circumstances, right? And particularly in the last few years when we introduced COVID into that mix, you're really compounding that situation for a lot of folks. Things like lack of diagnosis, lack of access to quality care, lack of effective care at every step of the way through the journey, lack of support from those around us. If you're not getting understanding and compassion, that can compound the trauma. Dealing with comorbidities, endometriosis is related to so many different other health conditions. So you can be dealing with endometriosis and something else or several other things as well. Infertility, very obvious one. Um, really feelings of shame, vulnerability, dealing with stigmas, lack of sexual satisfaction because it's so painful. Um, and it's very dynamic. It's a very subjective, multifaceted view. How you feel is how you feel. No one's going to tell you, no, endo can't cause that. Yes, endo can cause that. But really, on a physical level, it can also, the compounded stress can really lower your pain threshold. It really can have an effect on your brain, what they would call endo brain, right? Um, Dealing with multiple surgeries, multiple medical therapies, the side effects of those things, the psychological consequences of dealing with that failure. Um, Again, going in repeatedly for surgeries that haven't worked, perhaps they're done incorrectly or incompletely, that can do things like to screw with your cortisol levels, which is linked to stress and has, disturbances really on the HP axis or the hypothalamic pituitary axis. All of these things negatively impact stress management, your ability to deal with the stress reaction, um, and improper management. I mean, then we start talking about things like introducing opioids, not because people with endo don't need opioids, but that just introduces another level of complexity. So all of these things, as you can imagine, all of these things and more absolutely can affect the psychological well-being, the mental and emotional well-being, but it takes a toll on your body. And because it's lifelong and chronic in so many different cases, you can imagine that the disease really represents an incredibly difficult and huge life-altering source of stress. I hope that kind of sums it up and does justice. I mean, I could go on forever about all the negative impact of endo.
No, but I just love your explanation because you were so comprehensive about the complexity of the experience of the illness, how it intersects with other kinds of trauma. And as I listened to you, I was sort of checking the boxes in my own mind about how trauma is viewed from a clinical perspective. And I'm wondering if I could just spend a moment to share that perspective. Um,
Absolutely. I think it would be really helpful for our listeners and viewers really to understand, how we're defining trauma per se from a medical perspective, what you're seeing in your practice, things like that. I think that would be amazing.
So from a psychotherapy perspective, I think it's helpful to think of trauma as simply any experience that is overwhelming, that's beyond our ability to cope. As one of my colleagues likes to say, too much, too fast. And that often comes with a sense of powerlessness, feeling out of control. There can also be this subjective experience of feeling treated like an object, um, kind of as if our humanity is being revoked somehow. Um, and as other colleagues have written about, I think there are two central themes of that experience, and that is the experience of disempowerment and disconnection. Uh, and there can also be a sense of, in the middle of trauma, there's some sort of barrier to you acting on your own behalf. There's sort of this truncation of being able to save ourselves. And there are many complex reasons for that, but that's a theme that comes up over and over again. And what I also really loved about your answer is that you named the wide spectrum of severity of trauma. And, there are things we experience that are all those things, but a day later, a week later, a month later, we're able to get on with our lives. And then there are other events that are so searing that 6 months later, we are still re-experiencing them in some way, in a psychological way. We may be trying to avoid thinking about the experience. We may have intrusive thoughts that we wish we didn't have. We may have trigger responses, flashbacks. And this is the notion of post-traumatic stress. So after the trauma is over, the memories of it, the experience of it is still stored in our brains and bodies in a way that, as some of my colleagues put it, the past is present.
Right.
So what I really appreciated, you started by saying we need to think about trauma as far more than combat veterans and national disasters. And just to put one example out there that I heard from a colleague that I think sort of opens this up is to think about experiences of being in grade school, sitting in a classroom, and everyone in the room is making fun of you, let's say, for your acne. That is trauma. And so it doesn't have to be, the things that might show up on a movie screen.
Right. No, absolutely. And I think it's really important, and I know you agree. We talk about the brain a lot, and I mentioned the endo brain. That's not to imply that this is all in your head. It's in your head, yes, but it's very real. It's very visceral. It's very organic. And I think folks with endometriosis have been told for so long that they're imagining their pain, they're imagining their symptom, that it's all in your head, you're ruminating, you're catastrophizing, you have central sensitization, and you should think yourself well, and this notion of toxic positivity and all of these things, which in and of themselves can be traumatic BTW. I want to make it very, very clear. This is real. This is a real thing. And again, it can be compounded by so many different intersectional experiences. And I think one of the things that was so interesting to me, in just following your work, and as we have collaborated, when we talk about things like EMDR, and I thought maybe we could talk a little bit about that, because it's folks who work in sort of this space may understand it, but those who are kind of outside may only know it in the context of PTSD and not really understand that we've now really started to broaden the horizons on using EMDR for different types of trauma and cognitive help. Can you talk a little bit about what is EMDR, how we're using it, and then if we could, after that, I would love to touch on a case study that you did, because I thought it was so important.
Uh, Thank you so much for bringing that up. I'll tell you what, I'd love you to lay just a little bit broader foundation of endo itself before we get to the EMDR, but I definitely want to. And I'm wondering if you could just, now that we've talked about trauma, can you just elaborate on how the experience of endometriosis impacts mental health as a result of the trauma?
Well, absolutely. I mean, not only, can we turn to the scientific literature, the evidence-based literature, and immediately see an abundance of studies on the links between increased rates of depression, anxiety, and other mental health consequences of endometriosis, both from a physical and emotional perspective, as I talked earlier, things about androgenic signaling and cell-mediated immunity. All of these things are linked to anxiety, stress, depression, real physical effects as the result of emotional health and well-being. I mean, when you think about it, here's a disease that really comes from the most vulnerable part of you. I mean, it impacts things, like I said, sex, your relationships, your earning capacity, your ability to work in your chosen job, your family building and fertility, things of that nature. All of those things are so raw and visceral. Obviously, of course, it's going to have an impact, right? Now you go and you seek help for these things, as we're told we need to do. And then what happens? You get dismissed, you get trivialized, you get told it's all in your head. Have a glass of wine before sex, you'll be fine. Have a Xanax, you'll be fine. So it's just intersectional and compounded layer after layer after layer. So you've got all of these psychological consequences of living with this disease, and then you're being bounced from provider to provider to compound it and make it worse.
Yes.
So all of those things, again, they're going to really substantially impact a person's mental and emotional well-being. Um, and I think that we have started moving past, this notion that, well, I hope we've moved past this notion that endo is just painful periods, because of course it's not. It's a systemic disease that has, yeah, it may worsen during the cycle for some, but it affects non-menstruators. It affects postmenopausal, post-hysterectomy. It's not just a killer cramp. It's not just a bad period. It impacts bowel function, bladder, you name it. It's been found in the lungs. We're starting to move past this concept that it's just a bad period, and if you stop the period, you'll be fine. And really understanding that this is a biopsychosocial disease, and we have to address it from that way. We can't really come at it from a single provider perspective. You can't just have surgery, even in the best of hands. You should also look into other adjuncts, be it therapy, be it pelvic floor therapy, be it other adjuncts, be it all of the above. It's a multi-systemic, multidisciplinary disease, so it needs to be treated that way. So I'm a little heartened and encouraged to see that we are kind of moving past, like I said, that single provider gap that really hasn't done well for people with endometriosis in the last 50 years. So it's, we're way past time for that. But there's too many people falling in the gap still. Way too many people.
Yes. No, I'm so glad you brought up that integrated treatment perspective. And it leads to the next thing that I'd love to hear you talk about, which is a trauma-informed approach to care. Given everything you've just said, what does a trauma-informed care look like?
Absolutely. I mean, we talk about this a lot in our space, and I don't want to say it's become sort of the cause du jour, but we're definitely hearing more about it. And it's really being driven home more in the professional education sector, and I'm here for it, because I think, again, it speaks to doing away with that single provider model and really incorporating all of these mind body approaches. When we talk about trauma informed care, we're really looking for the components of a foundation of care that's really grounded in an environment that's calming and safe and empowerment. You touched on it before. It's really about giving the patient back their power. You have to understand and obviously have compassion, and ask about, recent or past traumas. um, how that person is dealing with them or not dealing with them, as the case may be. Um, but it's really about going into that shared decision-making space. It's about trauma-informed principles and understanding that, again, it's all connected, right? Everything is connected, and really using some strategies that really look toward I think the appropriate management of the situation, and what that management looks like is different for everybody. It may be a combination of physical intervention vis-a-vis surgery. It may be medical therapy. It may be pelvic floor therapy. It may be a combination of all combined with teaching of adaptive coping strategies. And when we talk about adaptive, it's adaptive or maladaptive. Obviously, as the name implies, maladaptive is sort of less helpful and maybe even problematic. But when we talk about adaptive, it's about giving the power to the patient, helping to teach them to learn and deal more effectively with life changes and stressful situations, particularly in the healthcare settings. Again, people with endometriosis have a lot of stress related complex diagnoses. If as I mentioned earlier, endometriosis usually doesn't come alone. You may also have adenomyosis. You may also have fibroids. You may have an autoimmune disease. You may have a cardiac situation going on. There's a lot of different comorbidities that are coming into play. And I think when we start changing the experience to something that really helps them regain control of their health, yes, but also helps them to adapt to and adopt, again, that biopsychosocial model in a way that they can do. It's about self-care, it's about self-empowerment, and really it's about self-advocacy, for lack of a better word. As the saying is, nobody's a better advocate for you than you, right? Um, but again, it's learning how to manage it using all the tools in the box. But the provider who is working with them has to be into that shared decision-making model. They have to be compassionate and they have to be trauma informed. They have to understand all of these things, these complex things at interplay. They all need to be addressed.
I love that. And again, everything you're saying overlaps with what I think a trauma-informed approach in psychotherapy is as well. So just to spend a moment on that, I think the most basic thing we need to start with, as a profession, is starting with the fact that we need to assume that everyone has a trauma history. It used to be the default was that's rare, but actually, and I'll put this in the comment section. There's a very famous, very large study called the ACEs study, which stands for Adverse Childhood Experiences, and it proved that the majority of people from relatively privileged backgrounds had some sort of trauma background. And so that's the starting point. Assume everyone has some kind of trauma, and some will be farther along in their recovery than others. And if you accept that, then you also need to assume as a provider that anything could be triggering to somebody. And when it is, you respond as best you can, knowing that you can't always predict that. But then it also goes back to what you were saying about empowerment, that if we think of the experience of trauma as an experience of disempowerment and disconnection, well, actually, that gives us a wonderful guide for trauma recovery and trauma prevention, which is continually cultivating a sense of empowerment and connection. Knowledge is power. And I'll never forget a nurse just mentioning casually that she felt like the job of nurses was to provide care, and the job of doctors was to provide cure. Mm. And I remember thinking, well, wouldn't it be great if both of those were everybody's job? And to create this sense of safety by everyone continuously providing information, choices, and therefore a sense of connection.
Absolutely.
And just as one tiny example, Imagine the situation of someone who is waiting to receive biopsy results from some medical facility. And the facility says, we'll call you with your results on Tuesday. And Tuesday comes and goes, and you don't hear from them. Wednesday comes and goes, you don't hear from them. And then you follow up to find out what's going on. And, something that can be as simple as administrative oversight, those 48 hours are going to be a traumatic experience.
100%. And I've experienced that more times than I can count. You wait for your results, you wait to hear about your biopsy, you wait to hear about your labs. And I mean, I don't know if it's better or worse that, sometimes you can go on your portal and you see them before they tell you. And you were expecting to hear on Tuesday and now it's Friday and you're seeing them for the first time. And it's like, well, ah,
Yes.
it's hard to process. Yeah,
Yeah.
definitely.
I remember a client was describing a similar experience, and I half jokingly suggested that maybe this medical office should not only have medical providers, but at the other end of the hallway, a group of mental health providers, so that after their appointment, they could get some psychotherapeutic support. And to her credit, she came back and said, how about we provide medical care that doesn't require a trauma therapist?
Well, that would be ideal, right? How about we stop traumatizing patients in the first place? How about that? How about we take people at their word when they say they have pain and we say we believe you, and we don't tell them that, that they can just eat an apple and meditate and they will be fine if they can just stop thinking about it and stop ruminating. I promise you, if you're living with a pain and symptoms that keep you from going to the bathroom and having sex and are doubled over and keep you out of work or school and away from your family functions, I guarantee you're going to think about it. So thinking yourself well is not a thing. Uh, that is not the same as saying that cognitive strategies can't help, because they absolutely can, and they're so important.
Right. So actually, maybe that's a good segue for me to go back to the original question about what psychotherapy and also EMDR can offer. And I've been thinking about this and thinking there are a few building blocks that I think might be useful to understand first about how psychotherapy could be helpful in these very complex situations. So I think the first thing that's really important for folks to understand is the relationship between pain and the mind. And I think the easiest way to explore that is to offer just two very brief scenarios. So let's say in the first scenario, you are engaged in one of your favorite hobbies. You're engaged in some kind of exercise. Maybe you're playing a musical instrument. Maybe you're gardening. And it's one of those things where you are completely absorbed and engaged in the zone for 2 hours. You don't even notice the time has passed. And then when you finish, you look down at your finger and see that there's a cut there. And there's not only a cut, but there's a scab. And you realize that in some point of doing this activity, you cut yourself, but you had no awareness that you did. The scab is already healed. And it's kind of surprising. Okay, second scenario. Let's say you're lying on the couch on a lazy Saturday afternoon. It's raining. You had to cancel your beach plans, and you finally promise yourself to read this book that a relative gave you, and you start to read it, and it turns out to be just not very good at all. You're kind of bored, and then turning the page, you get a paper cut.
Oh.
And you try to keep reading, and suddenly the stinging in your finger is so intense that you realize I can't keep reading at all. So what's going on in these two scenarios? Well, what's going on is our brain is doing a really smart thing, which is it is prioritizing our attention. And when you're using your whole body in something you really enjoy and you get a little cut, a very primitive part of your brain makes a little calculation to say, yeah, we don't have to worry about that right now. I'll let you know about it later. But then in the couch situation of lying on the couch, you're doing next to nothing and bored, and suddenly the tiniest stimulus completely dominates your thinking. So what I want us to take from this is simply that the mind is the mediator of our experience of all pain. that the pain may originate in some physical location in the body, but the mind is the mediator of our experience of it. And that fact is a way in for psychotherapy to having anything helpful to offer. So then the second layer of complexity in this that I think it's worth naming is the relationship or the difference between chronic pain and novel pain. So pain that's reoccurring versus pain that we're experiencing for the first time. So I'll offer two other simple scenarios. Let's say in the first scenario, you're in your kitchen, you're chopping carrots, and you nick your finger. And you've never done that before. And very often in that situation, there's a moment of complete disbelief. It's like, did that happen? Is that blood? And you may not feel pain right away. There may be this little delay, and suddenly you notice, oh yeah, that's I cut myself. Oops. And then you go to the bathroom, you get a Band-Aid and clean it up, and you go back to the kitchen and resume chopping carrots, maybe with a greater commitment to doing a little more slowly and mindfully, and you go on with the task. So now imagine you have the onset of a kind of pain that you have had on a recurring basis for years. Let's say it's lower back pain or migraines or menstrual pain. And you get the initial onset of this pain that you're very familiar with, and it is almost universal that the first thought we have is, oh no, not again. And it's very common that a follow-up thought comes of, oh my God, I hope this time isn't as bad as that time when it was really bad. And then if it persists, our anxiety goes forward to the future. And we begin to have concerns about how long is this going to last? How long is this particular incident is going to last? And then very often we go to an even farther future concern of, is this what the rest of my life is going to be like? So I see you nodding a lot.
1,000%. I mean, and it's easy to do that because there is so much uncertainty, particularly with all chronic disease, yes, but particularly with endometriosis. You don't know when a flare is coming, how long it's going to last. And that's an immediate thought. How long is this going to be? How bad is it going to be? What's it going to ruin this time? And is this forever?
Right.
Yeah, you definitely nailed it. So relatable.
So if we look at that a little more closely, the difference between our experience of chronic pain and novel pain is the role of memory. That the prior memories of this kind of pain add stress to our experience of it in the present. And one of the basic principles of working with pain is that virtually all pain is made worse by stress. I mean, you think about the nurse who's giving you an inoculation, and she's always saying, just relax, just relax. But the tense muscles make the hypodermic feel worse. And that's true of almost everything. So going back to this notion of post-traumatic stress from memory, what we now have is a situation where traumatic memories can make pain in the present worse. And that is an opening for psychotherapy to help. So what's really important, and you've already been saying this, but just to emphasize it, is that we shouldn't present psychotherapy as curing the underlying physical or medical condition. It's simply addressing the psychological component of the pain, which is very often simply reducing stress.
Absolutely. Yeah, I mean, I think it's pretty fascinating when you think about the concept of, focusing on the memory, maybe changing, and correct me if I'm wrong, but maybe changing the way that memory is processed and stored, if that's if I'm getting that right, in the
Heather,
most basic of terms.
Heather, I'm proud of you.
See, I'm learning.
So maybe I'll just give the briefest summary of a particular kind of treatment
Yeah, for sure.
many of my colleagues use, called EMDR. And so just to break this down, it turns out that to heal traumatic memories, research shows that we need to do at least two things. First, we need to find a way to somehow desensitize ourselves to the memory. so that we're not completely overwhelmed as we approach it, think about it. And if we're able to do that gradually over time, that allows us to, what you might say is to reprocess the memory. And one way to think of that is typically when we experience a trauma, we are in a state of fear and stress, and not all our problem-solving capabilities are online. So if you're able to revisit the event from a place of safety, you're able to make new meaning of the event from this new place of safety. And it turns out that if you alternately stimulate the left and right hand sides of the brain, there's something about that that facilitates this process of desensitizing and reprocessing memories. And there are a few ways that you can do this alternate stimulation. One is with eye movement, just alternate looking to the left and right. That works for some people. Other folks benefit from alternately tapping on the left hand, right sides of the body, on your legs, for example. And then you can also use alternating tones in headphones that can do this. And so this technique, and actually an approach to psychotherapy that relies on this approach, is called eye movement desensitization and reprocessing, or EMDR.
Excellent. Excellent. Now well, the others, yeah, you have done a case study. Others have done other work, sort of outside the realm of PTSD, really looking at how to use EMDR to treat a wide variety of pain and painful symptoms. There is some preliminary investigation into dysmenorrhea specifically. They've been a little bit inconclusive. And again, sort of countering that by pointing out again that endometriosis is not just menstrual pain, but it's interesting to see the evolution as it's sort of expanded. And to me, it makes sense, really given the EMDR approach and I guess the community, if you will, given their position on advocating, for trauma survivors, essentially. It just makes sense to me that we kind of look at it in ways to incorporate it into an approach to endometriosis. Again, talking about a disease that's really enshrouded in silence, misinformation, stigma, shame, all of these things. And again, not saying it's in the person's head, but looking towards tools that can kind of be incorporated to help them function and process it, and maybe self-advocate a little better. What I really liked about your study, and I'll kind of back up. So this is one patient, and you correct me if I get any parts wrong. This was one patient who essentially cut her pain in half, if I'm not mistaken. If I'm not being too gracious with that, I believe it was half. Using her EMDR sessions, and it was important to me to see that you really were very upfront, very honest about the fact that, look, there's no guarantee. EMDR is not going to work on everybody's physical pain, and talk therapy is not going to cure all that ails you. It's not going to treat your endo. It's just another tool in the armamentarium. It's a way for us to try to moderate maybe pain intensity, reduce some of the symptoms as this patient experienced. Really what I took from it was not an acceptance, like, oh, this is my lot in life now, because we've already been told that, learn to live with the new normal. This is your lot in life. Not that it was that, not about accepting it, but finding a way, as this patient did, to really practice self-care, not being mad at your body, but working with it
Yes.
instead of against it.
Yeah.
And I really, kind of appreciated the distinction that, all of the tools and adjuncts out there are not to imply that this pain is in your head, but this is just sort of a way that, we can look toward other mechanisms to maybe reduce the pain. Working on the consciousness towards dealing with our own thoughts about shame and stigma, again, so prevalent in endometriosis. And I definitely think it's, you're ahead of the game. Yours was the first study that I was familiar with at all on endometriosis as it relates to EMDR per se. So you're definitely ahead of the game. And it's definitely really a worthwhile avenue for research, I think. And again, it's about adopting and adapting to different coping strategies. It's about accepting that it's not a pill, it's not a shot, it's not one and done type of surgery. There's really different coping mechanisms we can use. And again, when we start talking about the biopsychosocial model, it stands to reason to me that this folks can benefit, from any cognitive approach, not just this one technique, but because yours was the first, it was exciting to see. I don't know how she's doing now, or if you can even elaborate on that, or what. But I mean, anybody who takes their pain in half, to me, that's a success.
Thank you so much, Heather. I really appreciate your perspective on that and validating the work we did. Because, as you say, I was very clear with her that um, I'm not a doctor. We can't guarantee this will work, but and what I will do is I will put a link in the comments to the narrative portion of the whole case. So I won't go over it all now, but just the highlights. She's someone who actually came to me initially for anxiety related to driving. And it really took some little bit of a digging to find the much wider experience of trauma that she had experienced. And I think that's extremely common, by the way, and that's another aspect of complex trauma, is that people
If
may
I
not.
may interrupt you, that is a perfect example of trauma-informed care, because you cared enough to probe and delve and find out that there were all of these other intersectional layers going on. So I commend you so wholeheartedly for that.
Well, thank you, but I have to say that's one of the things that I really love about EMDR is that it is an organic process, and it allows the client's mind to go where it needs to go to heal. And I just love that. The star of EMDR is really not the therapist or the technique, but the extraordinary adaptability of the human mind. And we're just providing scaffolding for the brain's natural healing capacity. But getting back to her, we had been working about 6 months, and she began a session. This was online during the pandemic, where she just blurted out, "I'm in so much mental pain. I don't know if I can continue the session." And I was aware of techniques to use EMDR on chronic pain. I introduced the idea to her with the caveats, and she was basically the point of, "I will try anything." And so what ended up happening was, over the course of about 6 or 7 sessions with our EMDR processing, focusing specifically on her experience of pain, prior to coming to me, she reported that her average peak period pain was an 8 out of 10. And after these sessions, she has reported that her average peak period pain is a 4 out of 10. And that is with an 18-month follow-up. Now, it's very important to emphasize that it wasn't just those 6 or 7 sessions. We worked together for about 2.5 years on a whole bunch of things. And as we talked about, since stress makes pain worse, I don't think it's an accident that this was helpful in the context of a more comprehensive approach to her entire trauma history. But I really have to extend my gratitude to her for being willing to risk telling me the truth in that moment that opened the door to another area of treatment.
Yeah. Patients are not just objects of change, they drive the change.
Beautiful. I love that. I
You
love
can
that.
learn more about this disease by listening to a patient than you ever will from any medical textbook or any kind of clinical curriculum. If you just listen to your patient, they will tell you everything you need to know. And I commend you again, on really coming from that trauma informed place. I mean, yes, obviously, you're a professional therapist, it's second nature for you, but really still so many practitioners don't. So I commend you on that. And I think this is an example that others can follow. I mean, there has to be some easy, well, quote unquote easy, right? But easy questions or probes that others can think of in their own setting. If someone comes to them, like you said, if it's highway anxiety or something of that nature, okay, well, let's delve a little deeper here. Is there something else going on? And I think if folks keep an open mind as they sit across from their client or their patient, start thinking about things that could be intersectional. It's not just necessarily one thing. Endo could be in the background of that landscape somewhere. And if you help them with that, that's a win.
Exactly. Well, and to that point, I also want to acknowledge you that after you read that case study and we talked a little bit more, you came up with 3 generic screening questions that any psychotherapist can ask and put on their intake form, that they don't diagnose endometriosis, but they're highly correlated. And so I'll just read them now, and you can write this any way you want, but say asking the patient on their intake form, over the past month, on a scale of say, 0 to 5, how much pelvic pain have you experienced? Do you experience painful sex? And do you experience debilitating periods that is impairing regular daily routine? And I just thought that was so helpful because, as my client said, she never dreamed that she would be talking about her periods with her psychotherapist. It wasn't on her radar at all. And it really wasn't on mine. But by putting this on the intake form, sort of people are put on notice that, yes, this is an important part of you. All parts of you are welcome here. And if there's something there, we can dig deeper. And I think that's another reason why I have stayed with wanting to learn more about endometriosis, because I now see how it is such a compelling, perfect storm of trauma that, as you said, there's the trauma of actually having the illness. There is very frequently medical trauma that goes along with misdiagnosing it and mistreating it. There is the social stigma around women's issues and menstruation in general. And then one of the things that I learned was that there is an incredibly high correlation between a sexual trauma history and endometriosis. And so you put all that together and, it's just something that I hope we can communicate to the medical profession, consider a trauma therapist, an EMDR therapist for these folks.
Absolutely. Again, we've stressed it so many times throughout our conversations generally. Um, Anything that helps the patient is a win. And that's not to say, a $12,000, online course by some influencer. I'm talking real strategies and tools that work, that help really center the patient, provide them with informed care and help them find ways that they are really back in charge. At the beginning, you nailed it. It's about self-empowerment and empowering the patient again, because so many things are taken away from people with endometriosis. They have to be given that back. They have to be given the tools. They have to be given the power. So often, so many people have been screaming to be heard, struggling in silence, being dismissed, which again is trauma in and of itself. Eventually, well, not even eventually, but almost immediately, that can impact care seeking too. So it's not just a question of, okay, the person goes home and suffers silently. They may have need of acute medical care if they've got ovarian torsion or a ruptured endometrioma or bowel obstruction or any things that are possible in the gamut of endometriosis. They're not going to seek care because they've been burned so many times.
Exactly. Exactly.
So all of the intersectional approaches are so important.
Yeah,
Anything that gives back power.
I couldn't agree more. So, Heather, we're running a little low on time as usual. This has been so engaging and so helpful. And I want to give you the last word, but I just feel like slipping in based on what you just said, just emphasizing that I think a key component of trauma-informed care is allowing the care to be completely individualized for each person. That, scientific studies are done in bell-shaped curves, but treatment is one person at a time. And by the way, I don't know if you want to show us your T-shirt.
Oh, this is Endoville's gift to me. I love them. I believe they've changed their name to Painful Peach now.
Okay.
But Endoville is just another one of those great and fantastic groups out there, doing such incredibly amazing work, supporting, educating, advocating. We have a good community. We really do. But yeah, this is one of their gifts to me, and
Nice.
I'm here for it. I'm a proud supporter.
Well, Heather, would you like to give us a last word to round things out?
Well, again, I always want to thank you, because you have just been a wealth of information for me personally and professionally. I think that this is not, although we can turn to the literature and find again an abundance of studies and endless technical jargon. I still think this is an under discussed area. So I appreciate you so much and the work that you're doing and bringing this conversation to the forefront. And again, I want to stress, as I've done throughout, it's not a question of this being in your head. This is not you've made your pain worse because you think too much about it or you went on Dr. Google. Endometriosis is a very real, very organic, very chronic, very painful, debilitating disease. In any way that we can empower patients to have adaptive coping strategies, whatever that may look like for them, that's what we should be supporting. And we've got to move away from that sort of single approach and really come at it from a mind body perspective, whether it's looking at the microbiome links or looking at the lesions themselves and not just menstrual effluent, or only focusing on women of reproductive age. I mean, there's so many unknowns about this disease that any tool that helps reduce symptom presentation and improve quality of life is something that we should be really looking into. So, and you're part of that. So thank you.
Thank you so much, Heather. This conversation has been exactly what I hoped it would be, and I'm just so grateful to you.
Always, always grateful to you. Thank you,
Okay.
Peter.
Until next time.